Hi, everyone, and welcome to ABC's Anesthesia. And today, again, another live Viva session. And we're going to have Megan back on the program. And this time, we're going to go through a bit of a tricky AAA Viva. So, Megan, and congrats on getting through the exam. Really fantastic effort. How do you feel?
Yeah, look, it's really good to have it behind me and be getting back to normal life. Hopefully, I'm not too rusty 2.5 weeks after last doing a Viva, but I guess we'll find out today.
I found out I was extremely rusty even the day after. I think that was
definitely.
Okay, let's go with this. So for everyone who can see this, it's on the screen, but for those who can't hear listening to the podcast, I'll just talk through it. This is the STEM, which take 2 minutes on. You are asked to review a 76-year-old man for planned abdominal aortic aneurysm or AAA repair on your list in 7 days' time. His aneurysm extends above the renal arteries. He has a past history of background of hypertension, type 2 diabetes, and a transient ischemic attack or TIA. He has a BMI of 32 and a 24 pack year history of smoking. He's also a Jehovah's Witness. His medications include clopidogrel, rosuvastatin, perindopril, metoprolol, and metformin. Now, the questions are, what is his risk of renal impairment perioperatively? And what criteria can be used to define acute kidney injury? So you can pause the video and take that time. If you'd like, write out an answer, write out your introduction and how you'd answer this question, and then we'll get started in the Viva in a second. Great, and that is about 2 minutes. Meg, so what is his risk of renal impairment perioperatively, and what criteria can be used to define acute kidney injury? And actually, before I start the question, when you get such a vague question, but that seems quite specific, how do you think about that? Like, what is this renal impairment perioperatively? It seems like such a nebulous question.
Yeah, I guess there's sort of two schools of thought here. One is to, make an overarching statement about the patient and the procedure. And I find that in about 50% of cases in my actual Vivas, I did that, and about 50% I didn't. I figured unless you could say something that really in, 10 seconds convey to the examiner that you got the crux of the question, it was best to just answer the direct question, but that's just my sort of thinking. And then in terms of giving, an answer to what's his risk of renal impairment perioperatively, I'd try and consider patient surgical and anaesthetic and medication factors in the context of the specific patient you've got in front of you, as well as generally as well.
Excellent. Well, let's get cracking. So what is his risk, do you reckon?
So I think it's difficult to give an exact number. I know that Miller's Our Bible of Anesthesia quotes approximately 7% in a case series of 500 patients having abdominal aortic reconstruction. But then there are specific factors to consider. So in terms of patient, he's got some demographic risk factors in the setting that he's, a little bit older. He's 76 years old. He's got a significant smoking history, and he's a Jehovah's Witness, which has significant implications for perioperative blood management and therefore perioperative hemodynamic, his perioperative hemodynamics, as well as his oxygen delivery to his kidneys, as well as many other critical organs. And then his risk factors pertaining to his medical comorbidities, which, we know that he's got diabetes, cerebral vascular disease, and hypertension. I would presume he's got some peripheral vascular disease, some CKD, and some cardiac dysfunction as well. Surgically and anaesthetically, I would consider his likely cross-clamp time, which will be related to the how complicated his aneurysm is, but also the surgeon performing his operation, any acute hypovolemia and anemia that he may suffer, perioperative fluid shifts, and the location of the clamp as well. So this patient will have a suprarenal clamp. And then pertaining to his medications, his ACE inhibitor as well poses some risks, as well as contrast. So it didn't specify in the STEM whether this is an open or an endovascular repair, but if it's endovascular, there will be a considerable contrast load as well, which will contribute to perioperative renal dysfunction. And I think it's important to, to state the caveat in the exam that, perioperative renal dysfunction or acute renal failure post major abdominal surgery is a significant predictor for perioperative morbidity and mortality.
Yeah, excellent. Now, and so Meg, what is the way that you classify acute renal dysfunction?
Yep. So I use the Rifle criteria, which breaks down acute kidney injury into risk injury, failure, loss, and end-stage renal dysfunction. In terms of the criteria itself, it breaks it down by the creatinine rise, that being 1.5 times, 2 times, or 3 times the baseline for risk injury and failure, and urine output defined as less than 0.5 mils per kilo per hour for 12 hours, for 6 hours, for 12 hours, and then less than 0.3 mils per kilo per hour for 24 hours, or anuria for 12 hours. And loss is for 4 weeks before proceeding to end-stage renal failure.
Yeah, excellent. So my next question after that is, so your junior registrar mentions that she has heard about a minimally invasive approach. What are the risks and benefits from a surgical and anesthetic point of view for the minimally invasive, so the EVAR approach?
Yeah, so I was going to say, what we're referring to here is EVAR, or endovascular aortic repair, which is typically done using a graft. The benefit specific to this patient is that EVAR is associated with significantly less blood loss, I believe 60% less, as compared to open aortic repair. And in this patient being a Jehovah's Witness, that's a significant benefit to consider. Mm-hmm. The major benefits and drawbacks were elucidated through the EVAR-1 trial, which randomized patients to either endovascular repair or open repair. And then in terms of endovascular repair benefits, there was a lower perioperative morbidity and mortality in the 30 days after the procedure. However, this benefit was not carried through at 5 and 8 years followed up, where there was no difference in morbidity and mortality, and there was significantly greater sort of re-intervention rates and long-term complications of EVAR over open repair, and a higher rate of secondary rupture. Yeah. Other benefits would be less perioperative pain, no need for laparotomy, and shorter HDU stay.
Excellent. So let's say, if you were to do an EVAR for this case, what anesthetic would you give this patient?
So if we were to do an EVAR, I would, my mode of anesthesia would be a general anesthetic. My method of anesthesia would be I would do a slow titrated induction, noting that this patient has significant cardiovascular comorbidities. And I would maintain this patient on a TEVA-based anesthetic because I really want to limit the chance of them having nausea and vomiting postoperatively, and therefore the chance of them having acute groin hematoma. I would give this patient an additional 2 anaemetics. The amount of analgesia required would be minimum. And in terms of my monitoring, in addition to my standard ANSCA monitoring, I would have a 5-lead ECG because I'm concerned about myocardial ischemia. And a 5-lead is just so much more sensitive for picking up ischemia than a 3-lead. I'd have an invasive arterial line placed before going off to sleep. And then in terms of my access, I'd have 2 wide bore cannulas because there is a risk of converting to open of about 2% and a significant risk of complications and rupture requiring a massive transfusion. I know that this patient can't have blood, but they still can have a acute I'm looking for the word, but essentially a resuscitation using crystalloid to maintain the same intravascular volume. I would aim to extubate this patient at the end of the case, and I would consider whether they would require a postoperative HDU disposition on the basis of how the procedure went, and also on the basis of their perioperative comorbidities. In terms of post-op monitoring, I'd be concerned of a number of complications, including acute renal failure, as we've discussed.
And so would you put a CVC for this case?
If it was a EVAR, I wouldn't. If it was open, I would.
Okay, let's progress. So let's say you've done a full assessment of this patient and you assumed a few pathologies there, which are absolutely reasonable. Exercise tolerance for this patient is greater than 4 mets. Let's say they're independent with ADLs, able to walk up 2 flights of stairs and do most of the things they need. They have no ischemic heart disease symptoms. Their bloods were taken and the HB is 100. The platelets are 200. Sodium is 135. Potassium 4.5. The creatinine is 80. And the group and hold is valid with no antibodies. So considering that information, what does your preparation for an open AAA repair for this patient include?
So in terms of my assessment of this patient, I would want to assess all of their comorbidities as we've discussed in order to ascertain their severity and stability and whether there's any room for optimization. I think you've sort of adequately covered that though. So in the actual Viva, I wouldn't go into more detail about that. You mentioned that they can climb up 2 flights of stairs. I'd probably still ask for a DASI questionnaire because as per the METS 2018 study, I think we've only got a 19% sensitivity for being able to classify someone as being able to obtain 4 METs. So I'd want to assess their functional status on that grounds. You state that the group and hold is valid, but this patient is relatively anemic. So I'd be wanting to look for a cause of that and optimize anything as far as I could, including iron supplementation. So I'd be doing some iron studies and I'd want to know if that was a microcytic, macrocytic or normocytic anemia. I'd also be having a discussion with this patient about patient blood management principles. They are a Jehovah's Witness, and what a Jehovah's Witness will and won't accept does vary slightly. Most won't accept the major cellular products effects of blood, but some will accept fractions and some will accept cell saver as well. So I want that carefully discussed and documented. And if they were accepting cell saver, I'd definitely be wanting to book that as well. Then we need to discuss the patient's medication management. So I would continue their statin. There is a renal protective effect of this, as well as, just general vascular patients should be on, a statin most of the time. I'd continue their metoprolol. Withdrawing that would increase their risk of MACE. And I'd be wanting to know the indication for their clopidogrel, but I'm absolutely leaning towards withholding that for 7 days. In terms of their ACE inhibitor, there's mixed evidence on this. The vision studies certainly do support discontinuing an ACE inhibitor, but the ACC-AHA guidelines state that it's reasonable essentially to continue or discontinue. So I like to have a tailored approach to that. If this patient had poorly controlled hypertension, I'd discontinue it. If they didn't, I'd continue it. If they didn't, I'd discontinue it. And then I'd consider the personnel that need to be involved in this patient's care and their disposition. So booking a HDU bed, discussing this case with the floor coordinator at the theatre complex, asking for a senior anaesthetic nurse to be involved in the case.
Yeah, great. Now, in this patient, you mentioned obviously there's contention about ACE inhibitors. Now, with this patient, let's say they did have poorly controlled hypertension, so ranging values from 140 all the way up to 190. But now you've got a case that you've rightly said this is a major blood loss risk case going open. How do you balance that? Would you, in this patient, knowing those two things now, would you discontinue or continue?
Oh, gosh, that's so difficult. Look, I think we're going to be having a period of clamping and unclamping. There's going to be hemodynamic instability. There's the increased risk of perioperative, blood loss and postoperative hypotension in the setting of, fluid shifts, major blood loss. You're right. I think I actually would discontinue it.
Yeah. Okay, good. Now, let's go with the anaesthetic plan. So you mentioned the EVAR plan. What is your complete anaesthetic plan for this patient?
Yep. So my anaesthetic plan will always include pre-op, intra-op, and post-op. I think we've discussed the pre-op component of this.
And you actually already mentioned GA, Artline, CVC for this case, and 2 big drips.
Yep.
Keep going.
My difference would be that I'd use a volatile-based approach rather than a TIVA-based approach, because I'm concerned about blood loss and therefore loss of anaesthetic drugs in the blood system and therefore awareness. I would use a volatile-based approach. I would use a BIS. I should have mentioned that for the EVAR as well, and I'd be titrating my anaesthetic to BIS as well. I'd be having a CVC.
Just to hold you up on that, what do you mean titrate to BIS? So
I'd be aiming for a BIS between 40 and 60, and I'd be titrating my volatile requirements to that.
Now, what's your minimum level for volatile? Let's say the BIS was 50 at 3 Mac. Do you go lower to titrate to 40?
At 3 Mac, as in
0.3 Mac. 0.3
Oh,
Mac.
0.3 Mac. Okay. Look, that's a difficult question. I think if it was 0.3 Mac, that's much lower than I would expect, even for an age-adjusted Mac. Noting that I think there's a 6% decrease in Mac per decade after 40, so we could calculate that out to consider what his actual Mac would be. But if it was 0.3, I don't think I'd be decreasing from there. So within the realms of what's sort of expected, plus/minus maybe 1 standard deviation on either side. And also I could also be looking at my signal quality index, whether there's any EMG sort of factors with that.
Actually, let's pause you there. What is your, considering that you'll titrate to some level of BIS, what is your lower end of MAC that you'd be happy with in this patient, providing there's relative hemodynamic stability and your signal quality index is good?
Probably around 0.6 age-adjusted MAC. I don't have an evidence range for that, just gut feeling. And
that's right. Keep going with your anaesthetic plan.
Yep. Obviously, our analgesic requirements at the minute is going to be much higher. This patient's having a laparotomy. Intraoperatively, I'd fentanyl load this patient, and I'd give him a fentanyl PCA postoperatively, as well as other opioid-sparing analgesia, which would include paracetamol. Obviously, not an NSAID in this circumstance. And then I'd be wanting this patient to have rectus sheath catheters or tap blocks plus catheters at the end of this procedure. Their disposition would be to ICU, and then I'd be monitoring, serial ECGs. I'd consider whether troponin monitoring postoperatively was indicated for this patient. There's a significant amount of literature coming out around that, and ongoing renal output and renal function monitoring via serial blood tests as well.
So you mentioned fentanyl-based with tap blocks afterwards. Any other analgesic management for this besides what you've said?
Yeah, so look, there is many of these patients will have a spinal drain inserted, and there is some consideration about whether or not a spinal-based anaesthetic, on addition to a general anaesthetic, can be useful with addition of intrathecal morphine. But this depends on local hospital guidelines. However, if this patient their disposition is to ICU, my institution would support up to 300 mics of intrathecal morphine, assuming no contraindications.
What are your thoughts on ketamine?
So ketamine has uses in the management of acute pain and the prevention of chronic pain. Typically, a loading dose is given at 0.5 milligrams per kilogram, and then an infusion is run at 0.2 to 0.3 milligrams per kilogram per hour for up to 5 days postoperatively.
Mm-hmm. Would you choose it for this patient?
I would consider his patient-related risk factors for poorly controlled acute pain. And then I would also consider his risk of perioperative cognitive dysfunction, as in many older patients, ketamine can increase the risk of delirium. That said, so can poorly controlled acute pain. So it would need to be a balance of risks. But I can certainly see a theoretical benefit in this patient.
Any other parts of this anaesthetic that you particularly will need to manage?
Yeah, so my sort of framework, obviously I wouldn't say this in a Viva, but my sort of framework for how would you give an anaesthetic is mode, method, specific medications, and moments. So moments that are important during the case. And in this case, those moments are clamping and unclamping. So in preparation, so in preparation for clamping, one needs to have medications prepared to manage the patient's blood pressure, as there's obviously an acute rise in SVR or an afterload. So typically what's used, or what I've seen used, it would be a GTN infusion via the central line that's been placed. In terms of drawing up a GTN infusion, I put 30 milligrams into 46 mils of normal saline, making that 30 milligrams in 50 mils, and then 1 mil an hour is 10 mics per minute.
What are your other options for blood pressure management on clamping?
On clamping. So those would include increasing the depth of anesthesia, especially given that the blood flow to the brain will increase and there can be increased risk of awareness. And then other vasodilators. So phentolamine is potentially also able to be used, but I've only ever seen GTN be used, to be honest.
Yeah, good. Let's move on. So let's say the surgery is pretty complex. The cross clamp is actually on for 2 hours. What are you most concerned about with a long cross clamp time?
So there are concerns during the period of clamping, and there are concerns during the period of unclamping. So during the period of clamping, this represents a period of ischemia to a number of different organs and tissue beds. And then in unclamping, this represents a risk of sudden drop in blood pressure because of a decrease in afterload, but also an influx of potassium and lactate, leading to hyperkalemia and ECG changes consistent with this, as well as a metabolic acidosis.
Mm-hmm. So how do you prepare for unclamping?
So there are clinical and logistic factors to consider. In terms of clinical factors, I would fluid load this patient. I would titrate down my GTN. I'd be prepared with a noradrenaline infusion. I'd have adrenaline dilute as 10 mics per mil and 100 mics per mil prepared. And I'd also check an ABG to know that the serum potassium was the lower end of the normal range. I would hyperventilate the patient to prepare for the possibility of a hyperkalemia and shift that potassium intracellularly with a slight respiratory alkalosis. I would also have medications for resuscitation prepared, which would be calcium chloride, 6.8 millimoles in 10 mils. I'd have insulin prepared and dextrose prepared as well. And then the logistic things are just making sure I have those medications available and making sure I have close communication with my surgeon so that I'm aware when he's about to, or she is about to unclamp, and I can discuss with them the possibility of staged unclamping or reclamping should we have significant instability.
Let's say the surgeon gets to unclamping, actually does it pretty suddenly, but you have done your preparations with fluid load, hyperventilate and everything. Now you see this on the rhythm strip. Imagine, I'm going to share the screen now. This is what you find, and miraculously get an instant ECG. This is what it looks like.
An instant 12-lead ECG.
Instant 12-lead ECG. What is this and what do you do?
So this is consistent with critical hyperkalemia. I would scan my monitors looking for...
What is that, by the way?
Oh, sorry. So there's peaked T waves. There's, and it's a broad complex. There's a tachycardia. Oh, sorry. Yep.
Yeah, that's great. You had me hello. What do you do?
Two ways. Yeah. So look, I would communicate with all members of the operating theatre, but most importantly, my surgeon, and I'd ask them to reclamp because I want to stop the influx of potassium. I'd also scan my monitors, looking for most acutely what the blood pressure is doing,
Let's say the blood pressure has dropped. It was maintained at 110. Now it's dropped to 70.
Okay. That's going to climb a little bit when we reclamp, but I'm also going to treat the cause of the instability, which is the hyperkalemia. So in the first instance, I'm going to give 10 mils of calcium chloride, 6.8 millimoles of calcium. I'm going to give 50 mils of 50% glucose and 10 units of insulin, Act Rapid. I'm also going to hyperventilate my patient further to shift that intracellularly, and I'm going to consider other methods of hyperkalemia management, which would include furosemide, although that can result in some instability, and salbutamol, which can be given either intravenously or down the circuit as well.
How do you give salbutamol intravenously?
So intravenously, you can give 5 to 15 mics as a bolus, and then you can run 5 to 15 mics per kilo per minute as an infusion. Obviously, this is associated with a tachycardia and a lactemia, which could worsen our acidosis. So it would be something that I would only do as a sort of last-stitched attempt before considering more invasive things like hemodialysis.
Just clarify your dose. How many? What's the infusion rate for salbutamol?
I believe it's 1 to 5 mics per kilo per minute.
1 to 5, great. Excellent. What else could you give? Let's say you've hyperventilated, you have given calcium, you've given insulin dextrose and salbutamol. Is there anything else that could shift potassium rapidly?
Yep. So one can give, so we've mentioned calcium, we can hyperventilate, we can give furosemide. Sorry, I'm struggling to think of what you're getting at. Yeah, I'm struggling to think of what you're getting at.
That's all fine. Let's go with now, let's say clamping happens, so stage unclamping occurs and the surgery goes ahead uneventfully. And then what do you, so let's say you're on the way to ICU, you've got everything you need for the transport, and then you see this rhythm on the way to transport. Let's say you've got everything you need for, as per the professional document. And I'm just going to show you that rhythm now. What is this rhythm? What do you do?
So this is a narrow complex tachycardia. The rate is approximately, it's difficult to say because it's irregular, but let's say it's about 150. I believe this is atrial fibrillation. So in the first sense, the difficulties around managing this is that I'm somewhere between theatres and ICU with a complicated patient who's just had a major operation. I'd be looking to see what degree of instability this is associated with, and if this is a perfusing rhythm, I'd be rushing very, very quickly to whichever was closer, theatres or ICU, to manage that.
Let's say the blood pressure does drop to 70 from its previous 100. You keep going.
If I was running a noradrenaline infusion, I'd increase the rate. If I wasn't, I'd give a bolus of metoprolol. I would give this patient a bolus of 250 mils of crystalloid and aim to stabilize them using that before rushing to whichever was closer, theatre or ICU.
Right. Let's say you get to theatre. Let's say you get to ICU. What do you do there?
So I'd involve the team that I was handing over to and explain what had happened. And then the urgency of management would depend on this patient's stability. If they were acutely unstable, acknowledging the risk of embolus, but also the fact that this has only been rapid AF for a very short period of time, I would do a synchronized cardioversion using 150 joules, noting that a higher energy is required to revert AF than other arrhythmias. If this patient was stable, then there would be a discussion between rate management and rhythm management, and we could consider amiodarone bolus and then infusion, or slowing the rate using, say, titrated small boluses of esmolol or an esmolol infusion.
Sure. What's the dose of amiodarone that you give as bolus?
So it's 300 milligrams over approximately 10 to 20 minutes, followed by 900 milligrams over 24 hours. What
are the aspects of defibrillation for this patient that you'd want to consider? How would you do it?
So I need to consider whether this patient, sorry, I didn't quite catch. I think you did say, though, did we extubate this patient or is the patient still intubated and sedated?
Let's say the patient's intubated and lightly sedated, 10 mils an hour propofol.
Okay. In that circumstance, on a very low dose of propofol, but tube tolerant, I'd give this patient approximately 1 to 2 milligrams of midazolam prior to a synced cardioversion. Then it would be a discussion with the team, and we'd be using the principles of DCR safety. So the pads would be placed on the patient on the precordium and in the axilla, and we'd be doing a synced cardioversion. And it's critical to make sure that the shock is synced, otherwise there's the risk of RNT phenomenon. And we'd use 150 joules, as I mentioned earlier.
Fantastic. Now, let's say that's all fine. Let's say as the patient wakes up in the next few days, you find that the patient has some level of motor dysfunction of the legs. What are you thinking of?
So I would break this down to the possibilities of a central versus a peripheral lesion. So a central lesion could be related to spinal cord ischemia during the period of clamping and unclamping, and related to the operation itself and fluid shifts perioperatively. There's also the possibility of an acute spinal canal hematoma if we had done a neuraxial with that intrathecal morphine that we discussed earlier, or placed a lumbar drain. And then peripheral lesions seem less likely to me if it's bilateral compared to unilateral, but be considering lumbar plexus abnormalities, prolonged surgery, positioning, and the factors related to that. I'd have a very low threshold to do an MRI on this patient emergently, looking for an acutely reversible cause. And in the first instances, I'd be wanting to maximize oxygen delivery to the spinal cord and minimize metabolic demand. There's more that you can do for the former than a latter.
What is the blood supply to the spinal cord?
So the blood supply to the spinal cord is via 2 anterior spinal arteries and a single posterior spinal artery. The anterior spinal arteries supply the anterior 1/3, and the posterior spinal arteries supplies the posterior 2/3. They come off the vertebral arteries, and the posterior may come off the posterior inferior cerebellar artery. And the drainage is via, I believe, 3 paired anterior and posterior lumbar spinal veins.
Excellent. And is there a particularly important artery in all of that?
Yeah, so there's an artery of Adamkiewicz, which is typically located around T10, although some spinal surgeons believe that it doesn't exist.
Okay, got it. Hey, mate, and that is the end of the Viva. Well done.
Great. Thank you so much.
No, thank you. Look, I think that'll be extremely intimidating for a lot of people because, you obviously do that extremely well. And I'll run through this now. So this is pretty much the session done for YouTube. I've got all of this loaded up on the final exam course at anesthesia.thinkific.com. And so we'll go through the feedback as well and the slides and that. Thanks very much for watching and listening, everyone. And now we're going to head off and give some feedback. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.